It's KUGN's Ask a Physician.
Ask a Physician is an educational program only. We do not give medical advice. The information we provide is not a substitute for professional care from your personal health care provider and is not to be used for diagnosing or treating a specific medical condition or disease. If you know you have or think you may have a health problem, you should consult your personal health care provider.
Now, Doc Talk on KUGN News Talk 590.
Indeed it is. Listen to that soothing music. It is a Doc Talk Tuesday, everybody. Good morning. Welcome to it. Thanks for joining us. In studio this morning, we have Dr. Geoff Simmons in for Dr. John this morning. Good morning, sir.
Good morning.
And you brought along a special guest, a gastroenterologist, and Dr. Andrew Mirhej. Good morning.
Good morning to you.
Glad to have you here from PeaceHealth Medical Group. All right, gentlemen.
Well, I'll tell you about Dr. Mirhej.
Okay.
Nicer doctor you couldn't find.
Nice.
Smarter doctor you couldn't find. I don't know how he can do what he does every day, but he is an extremely good gastroenterologist, and he'll tell you what that is.
He brought so many wonderful props.
He brought some props, and I'm being very careful. I drink my coffee and not something else.
Yes, right. Grant looks terrified.
Yeah, a little nervous.
Well, Katie Couric did it on the TV. We're going to do it on the radio. No, not really.
I can't believe she did this on the air.
Yeah.
I remember that.
So, Dr. Mirhej, what is a gastroenterologist?
So, a gastroenterologist is a physician that takes care of your guts. We work from, if you remember from biology in high school, the alimentary tract goes from your esophagus down through your stomach, your small intestine, of which there's about 20 feet, and your colon, which is also your large intestine. And we take care of all of that. As well, we look at the pancreas and the liver to help with disorders there.
Really important stuff, of course. I had a very good friend's wife die at age 62 from colon cancer, which is totally preventable if one goes about getting the screening, which we'll be talking about. And so this is a real easy subject to become very sophomoric about. And my wife told me, be serious, because it's important. So I'm going to try desperately. Okay. So we're not going to talk about your favorite colonoscopy or what you think about Beano. So why should I I'm over 50, why should I get a colonoscopy?
Well, unfortunately, Jeff, I know that you're a healthy guy. Certainly your mind is. It's clear that everyone over 50 in the United States is at higher risk for colon cancer, and that's why we do screening. Unfortunately, we can't use symptoms because a lot of times, even people with colon cancer, they won't have any pain, they won't have any blood in the stool, they won't have anything to tell them that something's going on, and this is why we do a routine screening.
It's a very, very silent disease.
Unfortunately.
So, how come it's only over 50?
Let him answer.
Well, certainly we've seen cases. I've seen a case as early as 23, but the majority of cases occur at 50 and older.
Okay.
Yeah.
Yeah, it's the incidence goes up as you get older, and so that 50 seems to be an easy point to cut off. But isn't there a difference in racial things too? There
are. Certainly for African Americans, we typically would like to start at 40 or 45. Also, if you have a family history of colon cancer, we'll often start at around 40 as well.
And when you're talking family, you're talking primary relatives like mother, father, sister, brother. I've even had sons and daughters who had cancer that we went ahead and sent the parents over. So primary relatives.
Absolutely.
Yeah,
got it.
Not the distant relatives. And so everybody says, oh, God, I don't want to do this procedure. And the reason is not the procedure. The procedure will describe to you, or Dr. Mirhej will describe to you, procedure is the prep.
Exactly. The prep is the thing that scares everyone away. I think that there's a couple of good reasons to do the prep. One, obviously, is so we can see what we're doing the next morning. The other is so you can join the elite, the few, the proud, the previously colonoscopied, who will have great stories about what happened during their prep. It's only second to childbirth in terms of stories that it generates.
It's so true. I have heard so many stories as I'm approaching that age. I'm hearing stories from friends that are already there and have done it. They're hysterical stories. Everybody has
I plotted out every bathroom between my house and the hospital. The one I had done, didn't think I was ever going to make it there in time.
I have to tell you, my best friend, when I didn't realize how intense it was, to do the prep and what goes into it and what you can experience. And but a best friend, I needed help. I had a flat tire, and he was the one to call. He says, "Absolutely not. I can't come." I'm like, "What do you mean you can't come?" I'm in the middle of my prep for my colonoscopy. Yeah. I'm like, "So?" And he goes, "No, you'll find out soon enough. I can't help you."
Well, for us young folks in the room, what do you mean by prep?
So good for you. So preparation is it is a liquid that tastes somewhat reminiscent of seawater from New Jersey. Unfortunately, the volumes are anywhere from 2 to 4 liters. There is a new 1 liter prep out that's a little more expensive, but frankly probably worth it. And so it's a large volume of liquid that you drink the day before when you're eating nothing, and all that's on television are advertisements about food. And you drink this stuff, and it runs through your intestines. You don't absorb it, and essentially it's like a tsunami that cleans you out. And it's sparkling clean.
And you can't go anywhere.
No,
good visual,
and
too.
You can't fake it. They can tell real quick whether you did it or not.
And if your laundry, you can't even do laundry or dishes if your restroom's not close by.
This is an extraordinary, interesting part of medicine because it lends itself to an awful lot of humor, and I'm sure Andrew's heard it all. But it's an extraordinarily important thing. I mean, it's when I ask, have you had your mammogram to a woman who's over 50, I might ask colon cancer history, and the next question is, when was your last colonoscopy? And if they found something, like Andrew can probably carry on here, I mean, there are polyps and then there are polyps. How often do you see polyps? So
a lot of times we're, on average screening, we're seeing it about 40% of the time. So and that brings up, a lot of people say, are there other tests we could do? I've heard about a special CAT scan or virtual colonoscopy or colonography. And those do exist, and you can use those for diagnoses. But unfortunately, if you have polyps 40% of the time, that means that you're going to then follow it up with a colonoscopy. So then you're having 2 procedures. So 40% of the time, we're finding polyps that are important. And a polyp is a growth of tissue that ultimately can become a cancer. So it's important that we take it out, and there's clear evidence that removing polyps reduces the risk of cancer.
Envision a piece of cauliflower or the tip of your finger or something like that, that they run into, and sometimes they can snare it and get rid of it, and sometimes they'll find cancer in there. People often say, there's no cancer in my family. I don't have any symptoms. I really don't want to do it. That doesn't work. It doesn't work. It's too common. Got a call?
We do have a call. KUGN News Talk 590. Good morning. Who's this?
Oh, hi, Storm. It's Lucas.
Hey, Lucas, you have a question for one of the docs?
I do. I had my colonoscopy done a few years ago, and it was clean. I mean, they said it was good, and I didn't even take any anesthesia. But another question came up. How often should I go in and have that wonderful experience? Is there so many years? I've got no history that I know of.
Well, I like the wonderful experience. Is there quotes around that or not?
Sarcastic.
Yeah. So, and good for you for trying that with no sedation. A lot of people that go into it saying, I'm going to do this with no sedation, do fine. Others were happy to make quite sleepy so that they just remember nothing. If you have no family history, then your next one, and the preparation was good, then your next colonoscopy would be due in 10 years from your last one.
Sweet.
Oh, wow.
Yeah, interesting enough.
Sweet.
And if you slip me $20, we'll make it 10 years in a month.
All right. Sure. Lucas, thanks for the call.
It's interesting because the folks who put to sleep will come back to us as primary patients and say, they didn't tell me a thing about what they did or what they found, because the anesthesia that they give has some amnesia to it when they wake up. They act the same. They give all the family secrets away. No, they don't do that. People are all convinced they're going to have dirty language. They're going to talk about their sexual adventures and anything that's secretive. That doesn't happen. At least I haven't seen it. But they often don't remember what they were told, and sometimes they'll be convinced that nobody told them anything.
Right. So, we usually make a habit of having someone there with them that we can communicate with, as well as we'll often give them a procedure report that has pictures that they can share with their friends or put on the refrigerator, and as well as exactly what we did. And certainly if there's any biopsies or removal of polyps, we call them within a few days to let them know what's going on.
No, there's very good follow-up, but it's so interesting how people don't remember.
Sure. Good morning. Got another question?
Yes, I do. Are you there?
Yeah, hi, Betty.
Yes, this is Betty. I have a question for the doctors. I'm 80 years old, and I had my colonoscopy about 2 years ago, and the doctor said, oh, you did fine, you'll never need another one. Well, if I hope to live another 10 years, why am I being singled out as I don't need another one?
Betty, I love the patient that wants to have more colonoscopies.
It wasn't fun, but the peace of mind is wonderful.
I completely understand your position. The good news is that if people get to about 75 and they haven't had polyps, then typically polyps are not going to be a problem for them long term. Certainly, there are people who are going to live to 100, and if they've had polyps, we will continue to follow them.
Oh, I see.
Certainly, but if you are 80 years young, then I would say that you've done great, and probably your lifestyle and genetics have contributed to a healthy colon. And if you are doing exceedingly well, probably in another 5 or 10 years, you could consider another procedure, but I would just count your blessings. I think
How do
you're
I
doing
make
great.
my colon healthy?
Well, I have, my mother died from colon cancer, and I have a brother that had it, 2 brothers, and this was my concern, and so I didn't
Absolutely.
want to be left along the roadside saying, tough beans, lady.
Yeah.
You're right. And so certainly with a strong family history, it would be something to consider again 5 years from your last one if your health is excellent.
Very good. Thank you. You have a great show.
All right,
Thank
have
you.
a great day.
Thanks, Betty. All
So
right.
let's find out how we can get our colon, or how at least scientists think we can get our colon healthy.
So, unfortunately, we live lives, I won't say of quiet desperation, but certainly they're crazy. I mean, the kids are screaming, there's bills, there's anxiety, there's the constant pressures of the modern lifestyle. And the way we eat often reflects that, and that leads to a lot of the problems in the GI tract, whether it's symptoms such as bloating or pain, or alteration of bowel habits such as constipation and diarrhea. Those things are really common in our society, and a lot of times I see patients that come in and they've got these symptoms, and we need to tease out which of these things are really concerning, potentially life-threatening, and which are the ones that we can work on through lifestyle changes.
Do we have time now for him to show the colonoscopies?
You know, we should take our first break and then come back with the colonoscopy.
Yeah, you need to see what we're talking
experiment.
about.
All right.
You guys are going to have to use your imagination.
We have cups here. Are we going to really taste this stuff?
Absolutely.
Yeah, and then we can all have a colonoscopy.
Yeah. All right, folks, stay close because this is going to be an experience not to miss. We're in the middle of a Doc Talk Tuesday with Dr. Geoff Simmons in studio and gastroenterologist Dr. Andrew Mirhej in studio with us as well. So stay close here on KUGN News Talk 590.
It's Doc Talk on KUGN News Talk 590.
Good morning, everybody. Yes, indeed, it is a Doc Talk Tuesday. Dr. Geoff Simmons brought along as guest in Dr. Andrew Mirhej, a gastroenterologist with PeaceHealth Medical Group. And just before the break, Lucas had called and asked about how often do you have to have it? Once you're 50, he had his, and he's thinking, when do I have to go back in? A year, 2 years? And your answer was 10 years. Mm-hmm. So then off the air we were talking, I thought 10 years. So, you're 49 and all of a sudden at 50 you got to have the test and you're clean, but what about a year, 2, 3 years down the road? Can't a polyp grow?
So, Storm, that's a good question. I think the polyps grow quite slowly, fortunately, in general. So typically we feel that the growth of a polyp from a polyp to a cancer takes about 10 years. So if you were clean at age 50, then even if the polyp started a week later, that likely we would catch it on the next colonoscopy before it became a cancer. The other thing is that not all polyps will become cancers. Only about a quarter of those that, if you were to just observe them and not remove them, would become a cancer. So it is a relatively slow process. However, certainly cancer can be devastating, and that's the main thing we're trying to prevent.
And this is an interesting area because there's a lot of areas of medicine we really haven't progressed much in 100 years. And this is one of those areas where we really have a life-saving procedure. And there are others, but this is one that's an obvious one, and it's relatively benign, especially in younger people. So we brought a scope along to show you.
For younger people?
No, this is for you. We want to show you what it is that he uses.
Okay. Oh, wow. Oh, my goodness.
Oh, my goodness.
Well, so do we see that before we have the procedure?
No, you won't do it.
Yeah, right.
Now, there's a couple things. The size is a little intimidating, but I want to draw your attention to one thing. One is the size of it is about the size of my pinky,
right.
So quite small. This is actually a pediatric colonoscope because you're a child at heart, and so that's what we would use. Now, they're kinder and gentler, frankly, and easier to maneuver. So I use pediatric colonoscopes about 99% of the time. The other thing you'll notice is it's not the proverbial garden hose. There's always people saying, you put a garden hose up there.
Right.
Well, it's obviously quite small.
Yeah.
Unfortunately, it's black, and there are no fashion colors available, but we're perhaps working on that.
And that smaller size, actually, you can slide under doors and see what people are doing.
Now,
Absolutely.
that scope, is that a camera?
Yeah, so
Okay.
essentially the camera is attached to a light source which travels down fiber optics, provides the light to illuminate the colon. And there's a video chip, just like in a standard video camera, inside of it, which then is transmitted to a giant monitor within the procedure room that we can see. So it's kind of like the incredible voyage through the colon.
Wow.
Without Raquel Welch.
And then, right, unfortunately. And there's a biopsy, there's a channel in here, an instrument channel, that we can put various devices down to cauterize things, to remove polyps, et cetera, so we can interact with the tissue and remove the polyps at the same time.
So what is the risk on this?
So the risks are actually quite small. I think everybody has gotten a lot better, and they're relatively minimal. For somebody who's healthy, the risk of sedation is minimal. Certainly people with breathing disorders or heart problems we take extra care with. There's a risk of bleeding if we were to remove really large polyps. Minimal risk of a perforation, typically somewhere between 1 in a couple thousand to probably 1 in 5 or 6,000. It depends on the studies you
And
look
it'd probably
at.
be an older, fragile person that would be more vulnerable, huh?
Tends to be, and they tend to occur on larger polyps where there's more interaction. And frankly, the other option for those people would be to have a surgery. So in some ways, we're trying to prevent them from having to have surgeries.
Oh, God, when I was first in my training, I mean, that's the only way we could take care of them was
Right.
a surgery.
Wow.
Interesting enough. And we used to, when the scopes came around, we used to look at things that I still have a visual image of that we didn't even know what they were then. Now we do. I mean, like Clostridia difficile.
Right.
I have a visual image of what it looked like years ago, and unfortunately the patient died because we didn't know what it was.
Mm-hmm.
This is very interesting. I think before the time runs out on us, because I know we have time, but it's real easy to run out of time.
Sure.
We want to hit on a couple other issues. And one of the biggest things we see in my office, and probably even bigger in Andrew's, is what we call IBS, or irritable bowel syndrome. You want to explain what that is and what we do about that?
So IBS, or irritable bowel syndrome, is very common. It's really one of the most common referrals that we see in our office. And really I think that probably in 10 or 20 years, we're going to be looking back at IBS as a larger umbrella over several other issues that we're sort of lumping together as irritable bowel syndrome. It's an alteration in how the intestines are moving, so the motility, as well as the body's interpretation of those. So people with IBS tend to be much more sensitive to their own intestines, and any kind of discomfort is often heightened. So it can be a combination of either having diarrhea predominantly, or having constipation predominantly, or sort of a mix of the two. And it can be obviously very disruptive to people's lifestyles to have this. I think most people in today's society, I mean, certainly if you've got a lot of bloating or rumbling in your gut 10,000 years ago, that probably didn't matter. If you're standing in an elevator these days, it probably does. So people come in for significant changes in their quality of life because of IBS, and the good news is there is no cancerous potential with this. Usually if they follow specific and typical interpretation of their symptoms, we can say that they have irritable bowel syndrome without doing a lot of procedures and other things. And there is help for it in terms of medication and lifestyle adjustments.
Now, you talked a little bit about bloating.
Foods. Yeah. Well, if you're on an elevator and you have to just let it go, you get off on the next floor and then catch another elevator.
So, sorry, Geoff, which elevator are you going to be riding?
Oh, my goodness. Okay, wait. On this note, there was a call.
Well, there's an opposite one, too. Is if somebody did it for you and you didn't, and then when people get on, you feel like saying, I didn't do it.
Right, I know.
Geoff, when's your 13th birthday?
Okay, listen, now I do have a serious question.
Yeah.
A question came in when we were off the air about bloating, and you just mentioned this. And older, female, and you start bloating. Is that something to be concerned about? Should you eat differently? Should you come and see a gastroenterologist? Why all of a sudden you start bloating when you get older?
So bloating can occur at almost any age. In fact, a lot of times I see younger women that come in, they're trying to be as healthy as possible. They're running, they're eating all salads, and they're saying, gee whiz, I've got all this bloating going on, and I don't understand what it is. Specifically, there's a lot of foods that we eat that cause the production of gas. And really the bacteria that are normal parts of our gut, what we call probiotics, are there, and they will sometimes digest the foods that we eat and produce gas, which makes us quite uncomfortable. And the common causes, certainly if someone was older, I would think about lactose intolerance, because even though people have enjoyed milk-containing products all their life, as we all get older, we lose the ability to digest lactose, which is the milk sugar, not milk fat. So you can't go to 1% and have any improvement. But that's found in milk, cheese, yogurt, ice cream, cottage cheese, the typical things. So holding lactose products for a week or two is probably worthwhile. You could try rice milk, you could try soy milk, almond milk, etc. Other things are going to be other vegetables that we typically eat that we like in stir fries, etc. So things like broccoli, cauliflower, cabbage, Brussels sprouts, certainly beans, and that would include lentil and sometimes soy. Can cause a lot of gas as well. So those are typical foods that we think about when people come in with bloating, and starting there is a good place, because it may be as simple as just cutting back on something.
You got to play detective and take away a certain food or food type for a few days and then put it back in and see if the problem comes back. And so, and like what he said with milk, you might be able to drink 2 glasses when you're a teenager. Time you're 60 years old, you may only be able to drink a quarter glass because you've lost a lot of the enzymes. And then there's people with rapid transit where, like the milk is digested in one place, but because they're nervous or they had a lot of coffee, it gets moved to another place, says, hey, I don't want this here, and it makes gas, and you're off to the races. And so it's sometimes just eating when you're nervous that can cause a problem as well.
Wow.
And it's common. It's a very, very common complaint in the office, what to do, and I'm bloated, and people don't believe that it's just gas. And there's people who swallow air out of nerves that can fool us. I've gotten older people who develop specific sensitivities, like salads, especially the leafy stuff. Mm-hmm. So we talked a little bit about IBS.
We do have a call. You want to take that call real quick before we get on to our next? Okay.
Sure.
Yeah, let's welcome in Gene. Good morning, Gene.
Good morning. I want to go back to the colonoscopy stuff.
Sure.
Both my father and my husband's father died of complications of colon cancer. I have 2 sons who are in their late 20s, wondering when they should start being tested. And you had mentioned earlier that primary relatives were more of a concern.
Right.
So mother, father,
So did you say your husband or your husband's father?
My husband's father and my father.
And your father.
Died of complications of colon cancer.
Right. So those would be second-degree relatives, and if they were asymptomatic, you could start at 50. There's a point when, and it gets a little technical, but looking at if there are multiple second-degree relatives, it can increase their risk. To be on the safe side, they could start at 40 if they're having no symptoms. But typically, with that far out, it would be probably at 50 for your kids.
Okay. All right. Thank you very much.
Absolutely.
Thanks for the call, Gene.
It's interesting that I'm going to change it to something else about ulcers being caused by infection. When I was in practice 20 years ago, I had a patient with emphysema. Every time I gave him antibiotics, he told me his ulcer got better. And I told him he's full of baloney. I could have been famous. I might have had the Nobel Prize.
In fact, the Nobel Prize was given in 2005 for the discovery of H. pylori.
Yeah, and I had it right there in front, looking at me.
Yeah.
I said the guy was crazy.
Yeah.
Yeah, so it's not the thing that you just treat with milk and have it go away.
Right. And so certainly ulcers these days are predominantly in the hospital. We see ulcers from NSAIDs, so anti-inflammatories like aspirin, ibuprofen, Aleve, Advil, those kind of things. And then secondarily,
can be very dangerous.
Yeah.
It can.
Oh, absolutely. And secondarily, H. pylori or Helicobacter pylori is a bacteria that people can live with their entire life, and it breaks down some of the defenses in the stomach and it leads to ulcers. And it's treatable with 10 to 14 days.
You're saying aspirin and ibuprofen, all the Aleve can lead to ulcers. How much do you have to take for it to?
It can vary. It can vary, but it can be a small amount depending on a lot of issues.
Wow.
If you're taking max amounts for long periods of time, you're asking for it. You're also asking for kidney problems. If you're a heart patient, you're asking for heart failure problems. There's a long list of problems. We probably should do a show sometime on over-the-counter meds and the worry. We started on this once, and we probably should do it. The other thing is, a lot of people say, oh, God, it's just heartburn. I'll take some antacids and I'll put up with it for years. But why should I see a doctor?
So heartburn is unbelievably common. About 10% of Americans have heartburn on a daily basis. So we see it all the time, and with the availability of over-the-counter medications, a lot of people are treating themselves. You'll notice on the over-the-counter Prilosec and medications like that, it says only take for 2 weeks, and the reason for that is they want you to not be treating something that could be scary or concerning, and they want you to see a doctor if things are persisting. Unfortunately, heartburn is the kind of thing that does persist, typically because of our lifestyle and our being overweight or just common to have reflux. So, this is something that you should see a physician if you have any warning signs, and that would be any trouble swallowing, if you have weight loss, if you have belly pain, if there's any evidence of bleeding. Those are red flags, and those people definitely should be seeing a physician. There is the concern of Barrett's esophagus. I think that's getting a little more airplay nowadays, and that's when the body changes the lining of the esophagus to deal with the constant acid that it's seeing. But unfortunately, when you change cell types like that, it's a precancerous condition, and can lead. Again, it's a low risk precancerous condition, but something that needs to be followed.
So, is this something you can prevent by seeing the doctor as soon as the reflux stuff starts, and you're worried about it?
Certainly, changing your lifestyle. So that would be eating perhaps smaller meals, not eating late at night and then lying down when you're going to have more reflux.
Sure.
High acid foods, all the things that we like to do in the Northwest, a glass of Pinot, a cup of coffee, all those things lead to more reflux.
And that's just breakfast.
Exactly. That was your breakfast this morning. So certainly all those things lead to more reflux. It's to be frank, it's quite tricky to say you can prevent Barrett's because certain people are going to get it and certain others won't.
Yeah, I get cases too who are older and they have bleeding with a bowel movement, and they say it's hemorrhoids and they're not worried about it. And of course they have hemorrhoids because almost everybody does. Should they be scoped?
If they fall into the right age group, et cetera, they probably should be because, if you said it's hemorrhoids, you're going to be right 98% of the time. It's the 2% when you're not that's concerning. Could they have a colitis? Could they have a precancerous or a cancerous polyp? Those are the concerns.
I just had a patient who had a gigantic tumor, and she kept telling me it was a hemorrhoid or two. It was cancer, big cancer.
She got in on time?
We're still seeing on this
I
one.
hope so. All right, we are in the middle of a Doc Talk Tuesday. We are talking with a gastroenterologist, Dr. Andrew Mirhej. We also have, of course, Dr. Geoff Simmons in for Doc Talk Tuesday. Any questions? This is the time to call, 541-686-0590. We've got one more break, and we'll be back on KUGN News Talk 590.
It's Doc Talk on KUGN News Talk 590.
Good morning, everybody. Okay, this is our last segment, and the phone calls are coming in. Good for you guys. This is the time to ask your questions as the doctors are in studio until 9 a.m. Dr. Geoff Simmons, along with Dr. Andrew Mirhej from PeaceHealth Medical Group, and gastroenterologist. And we've got Linda on the line with the first question. Good morning, Linda.
Good morning.
And your question?
My question is regarding, I guess, lesions that I have in my stomach that are bleeding slowly, and it's bad enough that I've had to have a couple of transfusions. And my doctor's treating me with omeprazole, but is there anything else I can do to heal this so that it doesn't continue?
So, Linda, good question. Omeprazole we kind of see as a panacea or something that we can feel like we could treat everything with, but unfortunately it doesn't address some of the problems. Lesions, it's a little vague, but you may have something called angioectasias or little tiny blood vessels on the surface of the stomach that can bleed if you're taking aspirin or something else, and it can kind of trickle out so that it can produce anemia, etc. And the treatment for that is cautery, typically. So you would go in with a scope, and then using a little cautery device, you just gently burn that area, and then the body heals it over with normal tissue.
what they said was that there were too many of them to be able to do that, and so I'm just, at a quandary about what to do. It's been going on for a long, long time, and I am anemic.
Definitely tricky, and I think that the goal typically is to try to get as many of those as possible, and then treat you with iron as well. Hopefully, not requiring to the point where you're not requiring transfusions, but it is a quandary for sure.
All right, Linda, thank you so much for the call. We're going to go now to Stan. Good morning, Stan.
Yes, I was inquiring about during doing the colonoscopy. Is the prostate observed at all?
So we don't see it because the prostate's not actually in the colon, but it's examined during the colonoscopy. So it's kind of a twofer there. So you're getting your colonoscopy as well as we evaluate the prostate.
And they probably wouldn't give you the report unless they found something they were worried about. But, yeah, they have to check that area. Huh?
I'm sorry, I didn't hear you.
I say they probably won't tell you in their report to you about your prostate unless, of course, they found something.
Oh, okay. Very good. Well, thank you.
All right, Stan, thank you for the call. Cooper's next. Good morning, Coop.
Good morning. So what does a person do to keep their colon more risk-free?
So
a higher fibrous diet?
So great question. I think he's a plant in the audience because we were going to talk about
that was
this.
the next topic. Yeah. Nice going.
Yeah. So those are good questions. And certainly, there's always been this talk about fiber and that fiber can prevent cancer. And my feeling about this is that fiber probably is good for the movement of the colon, but probably doesn't change the risks dramatically of colon cancer. Probably when you're eating a lot of fiber, you're not eating a lot of other things, and that might be a lot of meats that are fatty, for example, barbecued things such as when the fat hits the fire, you produce some carcinogens, which gets on the meat, which tastes awesome. However, it's not great for your colon. Cigarettes, unfortunately, too much alcohol in excess also can lead to increased polyps. But I would say that eating foods pretty much that your mom told you to eat in the first place, that's a good start.
Kids, you hear that?
Unless it's her pot roast, which is really you should stay away from.
All right, 8:53 now, you guys.
One comment back on the reflux, the heartburn. There's one other thing that you can do, and you can eat slower. What happens to folks is like at Turkey Day, on Thanksgiving. What happens is all the older guys with their bellies pooched out are all sacked out on the couch.
Right.
And what happened is they ate too fast and they ate too much because your body's about 20 minutes behind in telling you you're full. And so if you're hungry and you're starving and that smells great, you'll overeat. Now, once you've overeaten, there's no room for the acid but to go up. And so these people get heartburn and they really are bloated.
So slow it down, and oftentimes
Absolutely.
that can really just take care of the problem.
People wouldn't believe how fast they eat until you see them, time them or something like that. And the other thing about we call gas flatus, it sounds a little better. If you are a big producer, there are experimentalists who are around who want you. You can make money on this because they study diseases. Don't they? With what the flatus is composed of.
Was that on the internet somewhere? I don't know.
Dr. Geoff.
As an X-rated area.
No, but you're being serious,
this is
actually.
True.
These are
New
clinical
England Journal of
tests.
Medicine, man, it's right up there. 15 liters people and higher, and they actually are using flatus to tell, and breath as well, diseases without running blood tests.
Huh.
Yeah, the day may come. Hey, what do you guys do? In my day, I'm a little older than you, is the folks who got the colonoscopy, it was like a group of tubas practicing in the back room because they were all inflated. You guys deflate people now, right?
We do, although there is the 12-year-old in all of us that enjoy that symphony.
Why are you looking at me?
We deflate people before they...
Yeah, because it was really something else. I mean, that was the back room, and like I say, it sounded like a bunch of tubas.
Times have definitely changed.
Well, you'd be mortified if you actually knew.
Sure.
Yeah.
Oh, yeah. But you say we don't know. We're put to sleep, and we don't know.
No, we don't know. I like going to sleep on this one. I don't think I want to watch.
All right,
Especially if you find something.
You guys who didn't talk about what the gallbladder does, do we have time for that?
Go for it. Yeah.
Sure. So the gallbladder is attached to the tube that comes out of the liver. The liver makes bile, and bile is the green stuff that you see occasionally if you throw up, and it is like a detergent. So it helps to solubilize the fats that we eat. So if you eat your Big Mac, your gallbladder is now filled with bile, and there's a hormone that's released and that causes the gallbladder to contract. It squirts out the bile into the intestine, which then helps you to absorb all those fats that are in your Big Mac because we're wasting away, and we need those fats. And unfortunately, the bile that humans make is not the healthiest, to be frank, and probably in Body 2.0 we'll have a different kind of bile, but it is prone to make stones, and those stones can lead to blockages in the tubes that are coming from the gallbladder, and the gallbladder itself can become sick and quite painful and need to be removed.
Wow, what a wealth of information this morning.
What's interesting, though, is in my day, again, like the Roman era, we made a 6 to an 8-inch incision, and people are in the hospital for a week and in bed for a month. Now they do it with a scope, and they go home the same day.
Same day. It's
with a
unbelievable.
Band-Aid.
Yeah. It's crazy what we can do now. Well, this has been so interesting. Dr. Andrew Mirhej, PeaceHealth Medical Group. Really appreciate your time this morning. Dr. Geoff Simmons, always a pleasure. Where can we get more information about gastroenterology if we've got questions that weren't answered today?
I would start with your primary care physician, but at PeaceHealth, we're always there for you, and just give us a call.
All right. Okay. Thank you so much. Dr. Geoff, once again, it's been an adventure.
Yeah, exciting. Unfortunately, I drank some of the prep, so I have to leave.
I know. We actually didn't taste it, but they're going to make us, and we'll report.
No, I tasted it.
We'll report back. Yeah,
it's not bad.
Not bad.
I'm worried about you, Geoff.
How many more
years
till your next
I know where all the bathrooms are.
All right, everybody. Have a fantastic Tuesday.